Of the State Board of Pharmacy. Today's June 1st. Let's do a roll call. Alan, you want to start?
Alan Shad, professional member.
Amy Gutierrez, professional member.
Greg Lippy, public member.
Okay, first item on the agenda is public comment for items not on the agenda or agenda items for future meetings. Does anybody have anything? Okay, if not, we'll move on to the next item, which is enforcement matters. We have Jan Hirsch from UCSD on the phone, an update by UCSD on its pilot program to permit patients to access medication from an automated storage device not immediately adjacent to a pharmacy. The Board of Pharmacies approved a pilot to UCSD to perform under the auspices of UCSD School of Pharmacy, involving use of an automated storage device for prescription medication from which staff of Sharp Hospital in San Diego and their families who opted in could pick up their outpatient medications. Consultation, which was an issue for the board to ensure appropriate consultation took place, would be provided via telephone before the medication could be dispensed to a patient. At today's committee meeting, Dr. Hirsch is going to provide us an update on where we are with their pilot. And Jan, you on the phone?
I am here. Can you hear me?
Yes, you are up. We've got your slides up, so go ahead and we'll listen to your presentation.
Great. Okay. So let's flip to the first slide. You've already seen the title slide. You should be looking at an outline saying update, and I'll give an update on the operations of the kiosk and then also of the study. Those are sort of separate issues. And the next slide, please. So the go-live date for the kiosk was January 20th, 2016. It was located at the employee interests then, but there has been a change. For the original location was deemed hazardous because it was located near a fire exit corridor. And Sharp is not clear why this wasn't, discovered to begin with, because the original site was actually approved, inspected and approved. So they are relocating, and actually they just relocated on Saturday the kiosk to a new location, which is in an alcove on the first floor. And it does have, just as the other one did, it has 24/7 security cameras and on-site monitoring. And if you flip to the next slide, there's pictures, a couple of pictures. And the first one to your left is sort of the lobby area. And if you look through the door, you kind of see a light in there, and that's the script center in that little alcove. And then over to the right, there's a more up-close picture of the script center. So it is located in the lobby of Sharp Memorial Hospital, but it's in this little alcove. Okay. All right. The next slide, please, which is the enrollment slide. This is just an update on the number of users for the script center. We're about 200 users now. You guys had asked last time to put that number into some context. There are about 4,800 campus employees, fairly evenly divided between day shift and PM shift or variable shift. So the 200 represents about 4% of campus employees, to give you an idea of what that number is. The next slide. This is an update on the type of pickups. So it's broken down from refill prescriptions, which is the green part of the bars, the new prescriptions, which are the light blue, and over-the-counter medications, which are the dark blue. So we went live in January, and so that was when we were starting up to the left. And then February, March, and April, and this is just partial data for May. But you can see a large portion of the pickups are OTCs, and then new prescriptions and then refills. A note on the bottom here of importance is in these early months, what we were seeing was a high number of new prescriptions was due to really a high number of new prescriptions being transferred from other pharmacies into the Sharp pharmacy. So we're expecting the refills to sort of pick up. Those will turn into refills. An important note to the right of the graph is originally in our study design, we have estimated our sample size that we needed for our primary variable, which is return to stock, the RTS. And we needed about 140 prescription pickups per month to hit that 820 target. But if you can see this, we're not quite there. We're not sort of at that volume level of 140. So we've now estimated if we have about 80 per month of prescription pickup, we need 10 months, as opposed to the original plan with 6 months. So we are requesting an extension to collect data through the March, where we started already March. That was a study start. But we would like to go through December. The original plan was to go through October. I'm going to come back to that point at the end of the update, but I just wanted to explain why we're requesting that with this data. So I will come back to that.
Jan, this is Jenny. Can I ask a question?
Uh-huh.
Well, you can obviously hear me. Okay, that's good.
Yes.
You went live on January 20th, but you didn't start filling prescriptions until, is it March?
We did not start the study until the 1st of March. And the idea, the original plan, was to give the script center and the whole pharmacy operation a ramp-up phase to get to sort of a steady state of operations that would be reflective of normal operations.
Okay, so from January to March, you may have been filling prescriptions through the kiosk. Is that correct then?
Oh, yes, exactly. So,
Oh, yeah, they're on the,
slide,
yeah, January, February, and March are already there. Okay. Got it.
So this slide is showing you prescription pickups that have occurred in the kiosk. So the kiosk was up and running from January, and in February, our study didn't start until the beginning of March.
Thank you.
Jan, this is Amy. I have a question about the OTCs. When you state OTCs, are you saying they were truly just picking up like a bottle of Tylenol, or were these OTCs that were under a prescription?
No, these are OTCs like a bottle of Tylenol. They were not under a prescription.
So this is being used as like a vending machine as well for over-the-counter agents?
Could you repeat that one more time?
So the machine's being used, the automated device, in addition to the prescriptions, as a type of vending machine for over-the-counter agents?
That is correct.
Thank you.
Okay. If you move to the next slide, which you should see a yellow box on the top right that says pickups by time, and this is by time in the weekdays. And so you can see on the bottom the hours that the pharmacy is closed, the regular pharmacy is closed. And a lot of the pickups are being picked up at the kiosk, even when the pharmacy is open. So this was something we were interested in looking at, the volume of pickups when the pharmacy is closed during the weekday. Then if you flip to the next slide, it shows you the weekend, and obviously pharmacy is closed all weekend. And if you notice, the scale on this slide changed, and really the top number here is 18. So there aren't a ton of pickups on the weekend. And they're spread out through the day. It looks like 2 o'clock, which is probably some shift change. I'm not sure. Right, the next slide is a summary of this during versus after hours pickup. So there are 524 total pickups. There have been 334, 64% of those were during pharmacy hours, and the remainder, 36%, were after pharmacy hours. But then we divided between our 3 groups of new prescription, refill, and OTC. The percentage of new prescription pickups during pharmacy hours, about 73%. Refills is a little bit higher than that, like 78%. And the OTCs is where you do see a difference. It's sort of 50-50 between during pharmacy and after pharmacy hours. So more of those after pharmacy hours in the total our OTC pickups. Going to the next slide, which should say study design on the top. This is just a reminder of the study itself. Everything I showed you before was kiosk operations. The month 1 start in the center is March 1st. That's when our study started. We're going to be looking back at regular counter operations for the 6-month period, the pre-kiosk time, and looking at the return to stock rates. Then we'll be comparing that in our study time period, which is March through August, to the return to stock rate at the kiosk. We're also collecting counseling logs, measuring the time to pick up and satisfaction with the kiosk. Then we're also looking at the regular counter to compare to the kiosk during the study time period, the return to stock rate, and that consultation log, and the time to pick up. So that's where we are kind of with the study.
So
Next slide.
Go ahead. No, it's okay. I thought she was done. Go ahead.
Sorry, never mind.
Go ahead, Jan.
Yeah, we don't. Okay. The next slide is just to update the committee that there was a request for us to be able to analyze by therapeutic category. We have submitted that. The amendment had to amend the study protocol, and that has been submitted to the IRB, and I'm waiting to hear back, but there should not be any problem with that. And then the last 2 slides, so you should be looking at projected study timetable. This is the original timetable that we've been discussing. We are at the 2nd and 3rd quarter, so the post-kiosk implementation, and we're doing data collection and analyses, and that was originally planned for March through August. In the 4th quarter of this year would then be reporting the results to the board in the October timeframe, and we would be requesting to continue operating the kiosk at that time also. But then the last slide is a revised study timetable that we would like to propose and have an approval of. We would like to extend the data collection through December instead of just through September, October. And that would put the report to the board in 1st quarter of 2017. And at that time also we would be asking to continue the operation of the kiosk until the board decided on the results. And I don't know how long that would take.
I have a question. This is Greg, Greg Lippy. Are you doing a concurrent customer satisfaction survey to see how they like using this machine?
Yes, that is part of the data collection in the kiosk. Yeah.
Okay, thank you.
She's finished?
That's my last slide. The last slide says questions.
Okay.
Yeah.
So Jan, from what I gather from your presentation, the request is to extend the time period of the study to allow for more data collection and through the 4th quarter 2016 and report back to the board on quarter 1 2017. Is that correct?
That is correct. The data collection could spill over into 2017. We would like to have that little bit of extra if possible and have the waiver of the operation through the 1st quarter of 2017.
Okay, so do you want to move, you want to do additional data collection post-December?
I would like to report back to the board at the end of the 1st quarter of 2017.
We have a January board meeting, I believe, right around the 20th. Usually it's the 3rd week in January. Would that be too soon if the data collection closes December 31st?
When's our board meeting after that? Is it April?
It'll be April, probably. In
So
fact, it might even be February. Our board meeting might be February. I don't even remember.
Let's check the board meeting dates, because maybe we can give her some more time. We're just checking from Jan on our board meeting dates.
January would be really, really, really tight.
Okay.
I think I would like this is Laura Friedman from the board's counsel. I just want to, I think we need to verify what the dates are that were approved in the existing authorization. Well, because I remember that the board approved it, and then there's sort of a shift in the dates, and I just want to make sure that we're consistent with what the board did.
We are bringing this back. I believe the board is comfortable with the prior timeline. It has not had an opportunity to review the current timeline, which is why it's on this agenda in part. Besides that, we wanted a quarterly update anyway.
Right, okay.
Yeah, at the April 28th board meeting, the board approved the previous recommendation on the timeline. So I think the request today is to extend the timeline. Now, we just checked on our board meeting dates, Jan, and we're the third week in January, and then the next one is the beginning of May. So we could either have you report in third week in January, or we can look for the first week in May.
Sounds too tight. I'm going to make a motion to have them report out on our first week in May meeting.
So if you go through the first quarter 2017 and report back in May, will that work for you?
That will work study-wise, but may I ask, the waiver itself, can the kiosk still be in operation? Because we'll be in another quarter, and I'm not sure how that works with the board. You see what I'm saying?
So I think her additional request is to keep the kiosk in operation pending so maybe you might want to amend your motion.
I'll amend my motion to allow that to occur.
Your motion is to extend the time.
Extend the reporting time to our first week of May meeting and allow the kiosk to operate until we get the report.
And when you say extend the time frame, are you referring through the first quarter 2017?
Yes.
Okay. Or that timeline work for you, Jan?
That would be April 1.
Well, what I'm
Maybe
saying
longer.
is, wait a minute, the collection's going to be through December 31. That's the data they're going to use, but they won't be able to report it until our May meeting.
Or we can allow her to collect the data through the end of March.
We're going to allow her to collect it, but they're not going to be able to use it.
What we
Right.
may want to do is just, because when the board gets the report in May, it's going to have to act upon it, and there will be some time flow a little bit there. Why don't you make it through the second quarter of 2017 to end the study? And the board then, at the May board meeting, upon the results of the study, will have the opportunity to decide what it wants to do. That will allow them not to have to dismantle the Asteris machine. And instead, it gives the board a chance to review the operation and decide whether or not they want to go forth with a regulation, which will then mean potentially another extension, by the way, in the study.
So you're saying collect through the second quarter and then do the report at the
May
second
meeting.
quarter isn't until June.
Well, the second quarter would be, if we have a May 2nd board meeting, that's square in the middle of the second quarter of the year.
They can provide with an interim data report.
So an interim data report that goes through March, through April?
For April 1st?
Yeah, if that's what you guys want to do.
Well, how long does it take to actually, realistically, to put the data together and get to a report? Does it take 30 days? Does it take 60 days? What does it take?
I can do it in 30 days. I'm not getting any of the data until the end.
Okay, so if we, let's say to make it a little easier, we just collect the data through March 31st. We then report out in May on the data. The machines continue to operate until we make our decision
At the May board meeting.
at the May board meeting.
Will that work, Jenny?
Yeah, that'll work for you guys. And then you'll have a decision to either extend or basically terminate the,
Correct.
Laura, is that okay?
Does that work?
My concern actually has to do with the fact that the way that we notice this on the agenda is as an update. And so the request for the extension isn't actually noticed on the agenda. So I think if the committee doesn't have concerns, I think you can share the fact that you haven't had any concerns, but I think ultimately this decision actually has to go to the board directly.
No, I think we are under the understanding that everything we do here is probably going to go to the board. But do you have any concerns with the timeline that we just recommended?
I don't have all the dates. I feel like I don't have the dates in front of me for that, but I'll look at that more closely before it goes to the board.
Okay, thank you. So Greg, your motion is to have data collection through the first quarter.
Motion is to have data collection through the first quarter, have the report at the May board meeting, and allow the kiosk to operate until we make our decision at the May board meeting.
Second? Alan? Okay. Any public comment?
I have a quick question. Jan, this is Jenny. Have there been any consumer complaints that have reached someone because of the use of these machines or not?
None that I know of at all.
Are you in a
Everybody seems to
position to
like
be
it.
advised if there are any?
They said they're doing a survey, customer satisfaction survey concurrently with this, so they would know.
Well,
Right.
only
Yes,
if
but I'm
the
not
person
looking at it
complaining is gonna
on
be.
an ongoing basis.
Okay.
Another question I had, Jan, this is Amy, is the numbers that you're reporting, that's independent of the use for the OTC vending. Is that correct? We were just talking about prescription numbers?
The numbers that I'm reporting.
The number of
The numbers that
patients.
we're studying in the study are
Correct.
prescriptions, yes.
It's only for the prescriptions. So the number of patients are those that access prescriptions, not utilized
Yeah.
it for OTC vending. Okay.
Right.
Thank
I'm
you.
just reporting to you guys about the operation of the kiosks along the way. So you see that, but then the study portion is on the prescription refills and new.
Thank you. Jenny?
I just want to make sure I understand about the complaints. So if I was a patient, I used the machine, I had a complaint, the complaint would almost of necessity have to go to the pharmacy, is that correct? The actual brick and mortar pharmacy, not the machine?
There is the first, after the second time you use the kiosk, there is a little satisfaction survey that pops up and as you're using the kiosk. So that data, those data go to, through the kiosk back to Asteris, which is the company. And those data are being collected for me to study. I'm not exactly sure, but I can find out what else they might be doing with that data because I'm not involved in that side. Otherwise, a person would have to go complain, and I assume where they would go complain is the pharmacy.
Yeah, because a complaint and a satisfaction survey are really two different things. Okay,
Yeah.
thank you.
And the board has not received any complaints
We
regarding?
haven't, not that I'm aware of. Not that we've gone out to investigate, because I think that one would have gotten to me. But I'll check.
Thank you. All right, we have a motion, no public comment. All in favor? Unanimous? Thanks, Jan. We have going to recommend to the board the extension of the study and the May board meeting review. And that'll be next, that's not the agenda for next week. It's which board meeting is actually?
End of July.
End of July board meeting, the board will review this.
Okay, so that'll be recommended to the board on the end of July, is that right?
Yes.
Which is a Sacramento meeting.
Great. Thank you.
Thank you, Jan. Thanks for your time and for providing the update today.
Okay, thanks. Bye.
Bye. Okay, next item on the agenda is update on the Cures 2.0 prescription monitoring program. The DOJ announced that beginning January of this year, the upgraded PDMP program was available and all current registrants were required to update their registration in the new 2.0 environment to ensure access to the system. On February 8th, the board sent postcards to all licensed pharmacists as a reminder that California law requires all pharmacists holding an active California pharmacist license to register with Cures by July 1st, 2016. The board's working with DOJ to develop FAQs to assist registrants with understanding Cures 2.0. According to the reports generated by the Cures system, 30,544 pharmacists have registered to Cures 2.0, which is an increase of 22% as last reported at the March Enforcement Board meeting, or committee meeting. Additionally, over 344,000 patient activity reports were run in the last 30 days by pharmacists, indicating that pharmacists are utilizing Cures. The board is currently preparing a mailing to non-Cures registered pharmacists, reminding them of their obligation to apply for registration in Cures. There are 14,330 pharmacists who are not registered yet to access Cures, and of these pharmacists, a little over 8,000 have California addresses of record, and almost 6,000 have other U.S. addresses of record, and 202 have foreign addresses of record. The board is currently mailing a reminder letter to all of those pharmacists of their obligation to apply for registration in Cures by July 1st, 2016. So Jenny, can you give us an update on where we are with the registration? Is there any other ways of getting through to the pharmacists besides, because we still have a considerable amount that are still pending?
We sent letters. If you remember at the April board meeting, we had a discussion, and there was concern that postcards may not actually be reaching people because they get lost in the mail or something, so we sent letters. So these were actually in Board of Pharmacy envelopes, window envelopes, along with, on our letterhead, a copy of this letter, which tells people that we do not believe, the requirement is that they be registered to access Cures, not that they're actually registered. So it's kind of an unusual phrasing in the law. In addition, we give them information about how to become registered in the system. We give them a link to training videos at the Department of Justice. And then finally, we encourage them to join the subscriber alert system so that they can be kept apprised when there is additional information that's new that they have to comply with. We are not reaching a large chunk of our pharmacists and other licensees, and so we're going to have to explore various options of how to do that. But we've sent out subscriber alerts. We know that the associations have helped. We know that employers, the chain stores, for example, have helped get their employees registered and online. So we have done just about everything. I will tell you that yesterday I was contacted by the Senate, and they want to know what we've done to make sure our licensees have been registered in the system. So there is clear that we're going to have legislative oversight on what we've done to date to make sure that they have done this, and that we have done our part to fulfill our obligation to make sure our licensees are notified. We are also putting notices in with the new licenses as pharmacists become licensed, because the requirement does not kick in until they become licensed. So this is a prime time of year for us to be licensing pharmacists, so that when we send out the information to a pharmacist, congratulations, you fulfilled all the requirements for licensure as a pharmacist. Now you just have to pay $115 or whatever it is to get your license. We are also in that same letter saying that you have an obligation once you become licensed to register.
What's the flavor of the legislature with regard to the use of Cures as opposed to the registration?
Well, they want people to use it, but there is a mandatory use bill in for prescribers, but not for dispensers. And that bill, I believe, is still moving. I don't know the status of the bill, but it does make a difference when you look. I'm in the process, very slowly, of developing a PowerPoint that we intend to start giving as part of our CE outreach to pharmacists, where we show what would have happened had someone, either a prescriber or a dispenser, simply checked Cures. They would have seen some horrific dispensing by pharmacists and prescribing by prescribers for patients that should never have gotten the drugs in the first place.
Jenny, when was the last subscriber alert that we sent out?
Well, sometime between February and the end of April, we sent out at least one, maybe two in that period, because Cures had some updates, and so we sent those out. But we can do those. Those are easy, but those don't seem to be reaching the critical core. I understand the letters went out last week, and we were getting phone calls yesterday. It was kind of busy. So this is going to be busy for a while because we sent out 14,000 letters. So it's going to be busy for a little while until we get them. Some of these individuals may be pharmacists that really have quit practice, but they didn't want to retire their licenses. So as long as they maintain an active license, the requirement is they're going to have to be registered, and they don't know how to use computers. So those folks may have to make a decision to retire their license, and some of them have.
One of our commenters suggested that prescribers attach a copy of the cures with each controlled substance prescription that they send to the pharmacy. I wonder if that'll be part of the legislation.
It is not. The pharmacy has the access, and putting the reports out there is just an opportunity for the patient to see what he or she's got to do in order to help change her profile a little bit to.
Or modify it.
Yeah, exactly. That's where I was going, change the profile a little bit. So, in some states do allow patients to see their PARs. In California, there's no authorization for that.
They don't even allow
Really?
prescribers, because I actually had a question from a prescriber who said, I'd like to see if my DA number is being utilized. Can I see a report of all the prescriptions that I've written allegedly so that I can evaluate? And DOJ
I'm
says no.
surprised freedom of information wouldn't come into play there.
I would think that would be
Very
an
restricted.
important,
There's very high walls around the program.
I think it'd be important for prescribers to be able to have that kind of access to their own prescriptions that they've written
Right.
to identify potential misuse, but
Maybe we
DOJ.
should sponsor something.
So one thing we are doing is the unit is tracking the calls and what the outcome of the calls are. And so maybe we'll get a flavor from that, how many more people we registered as a result of this.
Can we, I mean, I think Greg has got a good idea. Is there any way we could sponsor some legislation to allow prescribers to be able to access their own records? Because I think that would help us additionally find diversion.
I think if that is done, the prescribers perhaps should be
Probably medical board
advocating it
would
for
have
it. Yeah,
to do it.
yeah,
Prescribers.
yeah.
Make that suggestion to the medical board. They may
Yeah, I
want
can
to
do
look
that.
at that. Because I know there's a lot of prescribers that are interested in that as well. Is there a way also to more prominently display this on our website? If somebody's checking on the first page when they log in, say you've got so many days, we can even do a countdown.
We can do that. We're in the process of updating our website too, to convert it to a whole new format. But yeah, let's see what we can do there.
What,
At least bring it down with the,
50
actually,
days, 59 days.
there's a prominent lobbyist in Sacramento who is not in the room at the moment, that wanted to do that on e-pedigree and cut down the number of days until you had to be compliant. I said, no, somebody would shoot me. So,
But this might
but
be a
this
good
one
one
we'll
to do that.
This one we can do.
And what happens on July 1st if we do have pharmacists that are still not registered with Cures?
Well, they're technically non-compliant, at which point we'd have to, one, make sure that they hadn't submitted an application to DOJ. Now, DOJ has now stopped handing out the paper registration forms. They want them to go to Cures 2.0 and register online, which is fast and easy, and you don't need a notary. So hopefully that'll solve the problem. That is really a question for the board. Generally, when we implement a new law, we do educational compliance to encourage them to go in. Rarely do we send letters to people we know are not compliant. So I think I would suggest that we do what we normally do and try to gently get people into the program. But the fact that I got contacted last night, what are you guys doing to make sure your licensees are becoming registered in Cures, kind of indicates that we're going to get some legislative oversight on this.
Well, given that legislative oversight, maybe we should start considering what we're going to do, given the fact that we aren't going to go before the board with this committee report until the end of July. By that time, we'll know how many people are actually still pending. But as the committee members think
You
we
want to do
should.
corrections? Do you want to do educational compliance? Do you want to do letters of admonishment? Do you want to do citations and fines? Do you want to revoke or limit their license? Those are your
I would
options.
think it would be good to give them at least a letter saying that you do need to,
Advance letter indicating that cite and fine will follow.
yeah, or a letter of admonishment or something will follow if they do not register in Cures by so many days.
Words to the effect the board is looking at its sanctions that are available should you fail to do
Right.
this.
Correct.
Makes sense.
And we can discuss it at the board meeting in July, but given the legislative oversight and the fact that it really is easy to register with Cures 2.0, this really shouldn't be that difficult.
We have some pretty large employers in the room I can recognize from some of you that are here. I'd encourage you to make sure your pharmacists also are registered to access Cures if you haven't already done so. So
And
you can help tremendously in this.
I think it's important to also inform them that the legislature's looking at this, so we do need to take some action and make sure that everybody's registered.
The whole country, the whole world is looking at this problem, so, I mean, this thing is
Big problem.
not going away. It's very hot.
So Greg, do you have a motion?
Yes. Motion is to do what we just said.
Ginny, you want to repeat that? Motion for Greg?
To continue efforts to promote our website in a manner that will help highlight cures, to send a letter towards after July 1 to see kind of where we stand if we can identify those individuals who we believe are not registered, and then to bring a report to the board at the end of July, at which time the board may want to trigger, okay, we're after July 1, here's your letter, let's get compliant.
They can discuss the progressive
Yeah.
actions at
That's
that
my
board
motion.
meeting. Second? Any public comment?
Quiet day.
All right, all in favor? All right, thank you, Ginny. I'll look forward to seeing that countdown.
I'll do what I can.
I understand, and I want to go back to the first item, which is public comment for items not on the agenda and agenda items for future meetings. My understanding that there's someone that wanted to suggest an item but was not here at the beginning of the meeting, so I'd like to open that up again. Morning, Brian.
Good morning, thank you. I was actually at the other building at 9 o'clock because I was thinking about next week's board meeting. Brian Warren with the California Pharmacists Association. It's a matter that the board has been discussing, or this committee has been discussing, and we have been in continued communication with board staff, and specifically Christina Costa. But we do want to continue to, or urge that the board continue to discuss ways of allowing where the board is comfortable with pharmacies using alternative testing methodologies for sterility testing of compounded sterile products. This was something that was discussed at the last board meeting. Based on that and some discussions with board staff, there does seem to be some pathway where the board, depending on the specific criteria that the testing facilities or the contract laboratories meet, that would allow pharmacies to utilize something like this. We do acknowledge that the board's regulations for sterile compounding don't take effect until January 2017, as indicated in those regulations. So we do have some time, but also would encourage that the board, continue these discussions and work with stakeholders to ensure that pharmacies have the ability to make use of some of these, technologies that have advantages over some of the old technologies.
Good morning. Mandy Lee on behalf of Pharmedium, seconding Brian's request to get this item agendized for a future discussion and action. I think this request comes out of our desire, the industry's desire to comply with the regulations that we will have to comply with come January 1. So we would respectfully request that the board take this item up, at least for discussion. And we hope that the last presentation that we gave was educational and gave the board a little bit more comfort and information around this technology that you once were not so comfortable with. And we'd like that discussion to continue. Thank you.
Thank you.
Thank you.
All right, moving on to the next agenda item, which is consideration of proposed regulation relating to reconciliation and inventory reports of controlled substances, currently to add Title 16 California Code of Regulations 7, Section 17.5.65. At the July 2015 board meeting, the board approved an initiation of rulemaking to establish inventory requirements for controlled drugs for pharmacies and clinics. The regulation initially was going to require perpetual inventory of all federal Schedule II drugs with a physical count every 90 days. Additionally, at that time, the board would establish a list of one or two several additional controlled drugs from Schedules 3 through 5 that would be reported as frequently stolen to the board and or to the DEA as part of this perpetual inventory. The regulation was released for the required 45-day public comment period between October 16, 2015 and November 30th, 2015. At the February 2016 board meeting, the board referred the regulation back to the Enforcement Committee to review to all the public comments received and consideration of the comments and suggestions. Comments received by the board and a copy of the proposed regulation are provided in attachment 2. Between the board meeting and today's committee meeting, Executive Officer Harold and I reviewed all the public comments and drafted a revised regulation, which is provided in attachment 2, which is entitled Proposed New Draft 52516. And in this draft, because of all the changes or all the recommendations and public comments that came from hospitals, the focus of this is to have a quarterly inventory performed every 90 days, and it's an inventory reconciliation, not just an inventory. Because I believe just counting drugs on a shelf doesn't mean much if you're not taking into account acquisitions and dispenses. For hospitals, I think this is the biggest change in the public comments we got, that the inventory requirements of every 90 days shall be only for drugs that are stored in the pharmacy. For any drugs that are stored in automated devices, we actually got some really good language from one of the public comments that Rita Shane submitted, by the way. She's right here, and that is on item H, which is basically states that the pharmacist in charge of an inpatient hospital pharmacy or of a pharmacy servicing on-site or off-site automated drug delivery systems shall ensure several things. 1, all controlled substances added to an automated drug delivery system are accounted for. 2, access to automated drug delivery system is limited to authorized facility personnel. 3, an ongoing evaluation of discrepancies or unusual access associated with controlled substances is performed. 4, confirmed losses of controlled substances are reported to the board. And 5, a clinic or pharmacy or clinic identifying losses of controlled drugs but unable to identify the cause within 30 days shall take additional steps to identify the origin of the losses and improve the security of controlled substance access to prevent losses. So because of the comment we received, we've actually in this draft removed any physical requirement of counting at the automated drug delivery level, given that this active process is going on. We know that this is an issue, though, that involves more than just pharmacy. It does involve other professions, physicians, nurses, anesthesiologists. But I think in this reconciliation inventory report, the expectation is that the pharmacist be involved in tracking and utilizing tools that are available to potentially identify causes, especially long-term trends. That's the focus. Any board member comments? Greg? How's the revised reg look to the two of you?
Oh, I like it. I like it.
Think it's better?
I try to decrease the...
Right.
But it still provides them a responsibility to track and trend.
I think
And take
it's-
action.
It's improved.
Public comment.
Hi, Christine
Good morning.
Driscoll from Dynalabs. I just want you to know that we've been kind of on top of this as well, and are informing folks that they can send samples to our lab to test for diversion, and we're seeing a large increase in that happening at the hospital level. So for any suspected diversion, be it an injectable product, it's mostly injectables. It could be hydromorphone, but a lot of them are fentanyl, morphine, hydromorphone. Those are the three. So typically, a hospital would like to see the results right away if they suspect, and we need a minimal amount. So they might look at a syringe and see that it's been used, and we usually need like 5 mLs to test it, but we can tweak it down to 1 ml, and that's usually what happens. We'll get one that they think has been pilfered, and Typically, they'll order a turnaround time of a day. They want the results right away, and we can do that for them. And we post those results, and I see them, and sometimes they come out at the right spec. Other times it's 30% potent, and so then it's up to the hospital then to take that result and take action. But we're seeing a lot of increase in the number of samples we receive for diversion.
There's certain drugs, Christine, that when you use a refractometer, it's very difficult to utilize. What are some of the drugs that fall in that class where they're sending them out for testing versus using refractometers?
So that we run everything under HPLC. I'm not sure if some people have refractometers, but they want to go further with the testing. And HPLC is like the top way to do that, or the most accurate method to test. So you get right down to what is actually the concentration of that drug. I think that's what you were asking, maybe not. Yeah.
And when you cite that you're getting more reports or more samples, are you talking about just California or the whole country?
Oh, the whole country. We're especially, it's interesting because I'll do follow-up when I see something that comes across. Utah recently had 2 hospitals, Colorado, and then I think it was Phoenix had 2 major hospitals recently. So in the last 8 months, it's been a number of hospitals, and I think everybody understands now that they have a narcotic issue, and we're seeing a lot of people that are reaching out to us in terms of hospitals are creating a position within their hospital system that's specific to a narcotic diversion specialist, if you will. It could be a pharmacist or something. It's mostly pharmacists. And we actually are, working with a couple of hospitals here in the Sacramento area to work with them on creating a more substantial diversion program. You go to hospital meetings and you'll ask, what is your hospital? What is the plan? What do you do to get the diversion plan in place? And they have a written diversion plan, and it's very subjective. And so one of the things that I was quite alarmed by was being at a meeting with a large number of hospitals, and what they would say is that the way that they waste narcotics is the watch program. So they basically waste in front of somebody in the OR. So there's 2 people that could potentially, have an issue with hey, I'll watch you if you watch me kind of thing. And so they're just dumping the waste, and that's how they're reporting how it was wasted. Now, we're encouraging hospitals to say, why don't you take your waste and bring it back to the OR, and then you can test it there if you need to, or send it out if you have concern. So I think that in hospitals, like that video said, it's more about the fact that they have access, and they're not questioned. It's different than taking a pill and putting in your pocket, I guess, but, so. Is that it?
Thank you.
You're welcome.
Good morning, Rita. Do you want to turn on your microphone? There should be a little green light.
Oh, got it. Thank you for, Rita Shane Cedars-Sinai, thank you for taking some of our input. A couple of questions and comments. One, with respect to hospitals, for organizations that have like the automated C2 safe, we actually do blind counts whenever we take anything in and out, so our inventory is always perpetually up to date. Would we still need to do a quarterly? Since that's like.
That would be, when you say at least quarterly, that would
More
count
Is
as.
at least quarterly, that
So
you're
it's more
counting it
often,
physically.
okay.
Just once
Okay.
every 90 days that you do that, that would count as your inventory.
Even though we're doing it every day? Okay, so we would just continue what we're doing. So I was trying to figure out a log for like an outpatient pharmacy that may not have automation. First question is, it says all C2s. Should we be doing all C2s or just opioids? That's a consideration. There's other drugs in there. And then and I'm just thinking to really do this, we probably want to do it monthly, because to do the reconciliation, you want to know if you have a variance earlier rather than later. So just wondering, would you want to focus on the highest volume ones and then rotate every quarter? Or you want, just other thoughts coming to my head of how to operationalize this in a way that we have a log that actually, I started to write a log out of how we're going to do this, a log that would account for it. And so 2 questions. One is all C2s or just opioids for consideration? And 2, rotating high volume ones to make sure that we get to them, and even considering doing it more often, because I don't think I'm going to wait for a quarter to find I have a problem.
I think the way this is worded is it says at least quarterly.
So
I
it's
know.
up to us for discretion to do
Yeah,
it.
in
Okay.
previous
that helps.
committee meetings, we had a lot of from the outpatient side, we had, for example, Ralph's Pharmacy Chain did a presentation, and they do it more often than that.
Yeah, 'cause
But
we-
since a lot of times the regulations we write is not one size fits all.
Right,
It has
so-
to, I mean, there's some hospitals that have very, very distinct processes for monitoring, and there's smaller hospitals that may not even have a pharmacist that's there every day. So we have to look at, that's why we put at least in some of these languages.
And then lastly, with respect to the refractometer versus sampling, one of the things that we would be concerned about if this was promulgated would be that technically all those things in the OR are contaminated. And so we've always been of the belief that we don't want those things coming back to the pharmacy, which is a clean area, because they're all contaminated. And there's no question that they should be evaluated periodically for, to prevent diversion, but they also should not come back to a pharmacy which is clean because of the infection control
I'm not sure
risk.
is there anything in the reg you saw that requires that?
No, I'm saying
Oh, okay.
future state,
Okay.
before we get, I know we're looking at, every organization is looking at how to ensure that they have I would say, an opioid management plan in place, including our own. And so we're looking at different aspects of how we can improve processes, and it's like it's a top ASHP issue too at the American Society of Health System Pharmacists level, so there's work being done across the country to look at what we should do. But I would just say that I would not recommend going forward and saying everything comes back to pharmacy, because now we've got dirty, contaminated medications coming back into what we call a clean area. So that's just a comment.
Now, the other process is how it's picked up, because I notice in some situations, if you have a pharmacist pick up those partial doses, now you've got one person that has access also to a lot of wasted narcotics, allegedly wasted.
Yeah, well, there have to be checks and balances. I totally agree with that part. Thank you.
Thanks, Rita. Any other public comment? Board members, should we move forward? Motion? Greg, you want, Ellen, I'm sorry, Laura?
Oh, I was just going to ask that if we could work on the wording of it, because I think there may be, if I understood correctly, the inpatient hospital is a slight, I would just like
versus
permission
hospital?
to work with you on the language without changing the substance of it.
That's
If we
fine.
could do that perhaps
We can do
next
that
week
before the board
meeting.
Okay.
That'd be great. Thank you.
Meantime, right, motion to approve the proposal.
The proposed new draft that's dated 5/25/16,
Correct.
and work with legal counsel on some of the language so that it's clear.
And that'll be
July, is it July?
Yeah, it's not agendized for next
It's
week.
not agendized for next week.
Okay, good.
We didn't have time. May I make a suggestion that there's actually a second part to the motion, that to withdraw the initial or to stop the existing rulemaking and to initiate a new rulemaking using this language?
Will you amend your
Yes.
motion to include that, Greg? Okay, is there a second?
And I'll second that.
Second, all right. Any other public comment? Yeah, all in favor, I'm sorry.
Oh, I just want to clarify. So the effect of that's going to be that basically all the comments that were previously submitted will be
Go
done,
away.
and we'll restart the whole process over
Yes.
again. So.
Right.
Yes. Okay, all in favor? All right, thank you. Okay, moving on to item D, Department of Consumer Affairs contract and audit of the DCA diversion programs provided by Maximus Health Services. The Business and Professions Code provides that various healthcare licensing board, under the auspices of DCA, may establish a program to identify and rehabilitate licensees whose competency might be impaired due to substance abuse or mental illness. The board is one of several DCA boards that have implemented such programs. However, the board's programs differ from those of other DCA boards in that it does not divert licensees from discipline. It uses the program as a monitoring program for its participants before, during, and after discipline is being secured. In 2003, DCA began contracting with Maximus Health Services to provide what DCA calls the Diversion Program services. In October 2015, an audit of Maximus was conducted for the contract period of January 1st, 2010 through December 31st, 2014. The report was referenced by the board in the 2015 Sunset Report, but never shared with the board specifically. So a copy of the audit is included in Attachment 3. So Jenny, anything that we need to review on this specifically that you'd like to point out?
Actually, no. I think that our pharmacist recovery program is an integral program for the board because our licensees happen to work in a pharmacy where they're around and surrounded by a lot of medication every day. So the constant and recurrent monitoring of fluids, the requirement that they go to counseling where they're eyeballed at least once, usually twice a week, keeps them in a position where we get additional information about the abstinence of our licensees that may be working in a pharmacy while they're either being disciplined or while they're undergoing discipline, and even post-discipline in some cases. So this gives us a degree of assurance we don't have. The interns and pharmacists are the only two license categories that are eligible for this. Technicians are not able to participate, and I don't know, we don't have the manager of the program in the room right at the moment, at least not that I can see her. So I don't know whether there's anything else. The report was required as part of our Sunset Review report, and we're providing it to this committee because the committee really should have an opportunity to review it, which is why it's being provided to you now.
Well, I mean, we've all read it, but the question is anybody asking that we, that's on, is anybody asking that we consider using it for a diversion as opposed to the way we are using, I mean, to avoid the discipline as opposed to using it in conjunction with the discipline?
There are periodic questions the board may receive or others may receive, but generally part of the concern the legislature has with the diversion aspect is who's really taking care of consumer protection when that occurs. And for us, because we walk into a pharmacy and there are literally thousands, tens of thousands of pills in that pharmacy, for us to be
Right.
able to walk in and identify diversion is a difficult thing until it gets to a particular level, which is part of the reason we have the reg that we just got
but
through talking about.
I guess what I'm asking is, other boards use this Maximus program instead of discipline, right?
There are some boards that use it as a cost reduction, and then they use it, some of them in conjunct with it, even for the same board will have both sides of it. But for us,
But
our
nobody's
program
asking
from the
us to do
beginning,
that.
yeah, no, from the beginning, our program has been set up like this.
Well, it looks in reviewing it, only 50% have successful completion.
Overall, yeah, overall.
Whoa, that's actually.
Addiction's a tough thing.
Oh, but it's considered good.
And the other question I had regarding on page 22, when it goes over some of the costs. So our Board of Pharmacy costs, the participant copay is $100 a month.
That's all they pay, we pick up the remainder.
So some of the boards, I mean, I'm looking, there's like $338. There's some that are $1,600 a month.
I don't know what that is. I don't know. Ann, do you know who's paying $1,600 and why? Because you have to come all the way up to the front. That was a way of summoning you.
Also, it indicated
Yeah, and I knew we'd get you up here.
that over 5 years, it can cost up to $90,000.
Well, in addition, keep in mind that that's just the administrative cost. They still pay for the group meetings and they still pay for their urine screens. And if they have additional counseling, they have to pay for their own recovery. But we do pay a portion of the administrative cost, which is part of what we're charged by Maximus to run the program.
Does nursing pay more? Because they're $25 a month, so do they pick up more of their fees?
So there's different costs associated. So there's the administrative cost, of which our participants pay $100 a month, and we subsidize the remainder. And that's a cost that is per participant, irrespective of the program that you're in.
What is the remainder, Ann, that we subsidize?
220, I think. It's up
Gosh,
to about $300.
I think we subsidize, I think we pay, our portion is about 150, maybe a little bit more. It goes up every year based on the contract, so I apologize, I don't have those numbers. So a couple of things that I just wanted to quickly highlight is part of the sunset review process was the board's opportunity to detail its compliance with SB 1441 standards. And this audit was specific to the Maximus program to confirm its compliance with SB 1441 standards. And if you look at the findings, there's general compliance with all of that. The audit did make recommendations on various elements, and so you can see those recommendations. And then if you have questions on any of them, I'll provide the context that I can if I have it. With respect to the cost specific to Board of Pharmacy, there's the administrative cost, which is the cost to kind of run the program, but then participants incur various other costs. And there is a table in there, and I apologize, I don't have it in front of me. There's a table in there that gives you the low and the high end for our participants. So depending on someone when they get into the program, if you look, the first year can be quite significant in terms of cost, but a lot of that is attributed to doing inpatient treatment. And I do want to let you know that we do work. There were comments made in the report itself about, working with counties and things like that. One of the things that we ask our case manager to do is to work with participants to find opportunities, if their insurance is not going to pay for it, to find opportunities, whether it's through a county bed or something else, to ensure that the cost is not preventing someone from going into the program. So we do try to address the financial concerns. Also included in there is a provision in the contract for our board specifically where we can waive the copay that a person would pay for the administrative costs. And in those cases, the board then does fully subsidize for that participant. We do evaluate their finances and determine whether or not they can be done, and then we generally do that for a period of time.
And that copay that we would be subsidizing would be?
It's the administrative cost,
It's
so it would be that $100
no,
a month.
How
They
much?
pay 100, the total cost is 315, so we're paying 250.
two,
And that
so
was
in
as
this
of
case,
last
we'd
year.
pay
It's gone up from this, so figure it's going up about, I don't know, it looks like about $15 a year, so it's up to probably, this year would be $330.
And how long, on average, are individuals on this program?
So it's generally 3 to 5 years, but it really does depend on the individual, and it depends on what the underlying issue is. So the program can be used for both mental health as well as substance abuse, and then there's dual diagnosis people. So it really will depend on the individual, but the general time frame is 3 to 5 years. One of the comments, one of the findings was that they recommended that there be longitudinal studies done of participants to see whether or not they maintain their sobriety, and that is something that we already do as part of our contract. They are required to do the longitudinal study. I believe it's 3 years after they successfully complete to see how they're maintaining their sobriety.
So the board's essentially funding about $2,400 or around that per
For administrative
individual
costs,
for
yeah.
administrative costs that are on Maximus for 3 to 5 years.
Right, but here's what the benefit is, because you know how long it takes us to discipline a licensee before they can get into a mandated program based on a disciplinary matter for the board. If they enter the diversion program upon discovery of the problem, they can be a year and a half into sobriety before they ever come to you for discipline, which is why we still keep them on discipline, because it is a recidivism type illness or condition. But nonetheless, that is taken into consideration at the time we're settling the matter. Meanwhile, they've been monitored for 15 months to 2 years while we do the discipline, protecting the public in a manner we wouldn't be able to do. We can't go out twice a week to see what the licensee's up to. It just isn't going to happen. So it's for us, we see it as a very strong and vital consumer protection element of our program.
Thanks. Ann, are there any other recommendations from this that you believe the board needs to act on?
I think that some of it is a policy decision for you all. I think that they raise some issues, and but we are one board within a generalized contract, so we do have the ability to put in board-specific contracts, but really the contract itself is really driven by the 1441 standards that were adopted, as well as then some additional enhancements that we feel were part of the program actually before that we feel were necessary to maintain.
We've essentially done that with this 1441 changes.
Yeah, so the
Long time ago.
1441 changes were amended in, but where we were more stringent, when we felt that that was necessary for public protection, we did keep those similar to our disciplinary guidelines. Our disciplinary guidelines, we're amending them to include some of those standards, but we're not watering down what our requirements are.
Thank you. Any other board member comments?
Yeah, it is encouraging that the rate of success is 4 times better than expected the general public, but you can see why.
Yeah, there's a lot of work that's put into that.
Well, that plus you've invested a considerable amount of your time and money in your education, and it becomes an element of your identification. And so that is a strong hold on you to move to recovery.
So the amount of pharmacists, I mean, a pharmacist would be better able to pay this than a technician. They're still charged the same amount regardless of their title. in terms of our
Technicians aren't
subsidy?
part of this program. Technicians are
technicians-
handled differently.
Oh.
Technicians are put on monitoring programs where they may have to go to Narcotics Anonymous or Alcoholics Anonymous, and they do get urine screened, but they do not go to the same group meetings, and they're not part of the Maximus program. And that's in part because part of the concern there is by having them go to the same group meetings, you've got a technician that you may be working with in a supervisory role where that technician now knows your story when you're going into the group meetings. So they're kept separate, and it has been put that way from the beginning. So, and the technicians cannot afford the cost of the program otherwise.
$100 a month?
Well, it's more than that, because they still have to pay $100 typically a week for urine screens. And then if they have to go to therapy of any sort or inpatient, it's very expensive to go through rehab. And some employers have programs that help technicians too.
Thanks. Any public comment? Okay, we'll move on to item E, which is consideration of the Food and Drug Administration's required class-wide safety labeling changes for opioid pain medications. On March 22nd of this year, the FDA announced required class-wide safety label changes for immediate release opioid pain meds. Among the changes, the FDA is requiring a new box warning about the serious risks of misuse, abuse, addiction, overdose, and death. The FDA is also now requiring a warning that chronic material use of opioids during pregnancy can result in neonatal opioid withdrawal syndrome, which can be life-threatening. Provided in the packet is a sample of how the new black box warning labeling might appear. In addition, the FDA is requiring several safety labeling changes across all prescription opioid products to include additional information on the risks of these medications. Copies of the FDA's news release and safety announcement are provided in attachment 4. Any board member comments? Public comment? Okay, moving on to item F, which is consideration of the CDC's guidelines for prescribing opioids for chronic pain. On March 15th, the CDC released 12 recommendations for primary care clinicians who are prescribing opioids for chronic pain outside of active cancer treatment, palliative care, and end-of-life care. The recommendations are grouped into 3 areas. The first is determining when to initiate or continue opioids for chronic pain. The second is on opioid selection, dosage, duration, follow-up, and discontinuation. And the third area is assessing risk and addressing harms of opioid use. The categorization of the recommendations was based on several factors. One, there's no evidence that shows that there's a long-term benefit of opioids in pain and function versus no opioids for chronic pain with outcomes examined at least 1 year later. The second, there's extensive evidence that shows that the possible harms of opioids, including opioid use disorder, overdose, and motor vehicle injury. Third is extensive evidence suggests some benefits of non-pharmacologic and non-opioid pharmacologic treatments compared with long-term opioid therapy. They produce better outcomes and less harm. A copy of the CDC guideline and the board's January 2013 letter of support to the CDC are provided in attachment 5. This guidance is addition to guidance provided by other agencies on opioid prescribing. In November 2014, the Medical Board of California produced its guideline for prescribing controlled substance for pain. According to the Medical Board's executive officer, the Medical Board is in the process of comparing its guidelines currently with that of the CDC. Hopefully to update, Jenny?
They believe that, excuse me, that the CDC's guidelines are a little more specific, and so that they're looking at adding, perhaps, depending on the will of their board, some specificity into the California Medical Board's guidelines that are already contained in the CDC guidelines, so that there's a consistent policy recommendation. It sounded like the Medical Board generally liked what was in the CDC guidelines.
Good. Well, this is it's a big issue, and it's going to, I think it all starts a lot with the prescribing. I mean, that's where this all begins sometimes, even the quantity, in terms of giving the quantity of medications that are given for specific diseases or conditions. Any board member comments? Public comment? All right, we'll move on to item G, which is proposal to add statutory authority relating to registration with the Board for automated drug delivery systems for dispensing of medication. At the February 2016 board meeting, the board considered a draft proposal to establish a registration requirement for pharmacies that operate automated drug delivery systems, which are outside of the pharmacy. During this meeting, the board discussed creating inventory requirements for these devices and the need to clarify some of the terminology that was used in the draft language. The board also heard public comment, where the board was asked to modify the requirements for hospitals that use automated drug delivery systems. The board asked staff to modify the language and bring it back to this committee for further discussion. So a copy of that language is on page 6 of the attachment for this meeting. And the board worked with the with myself and the vice president to refine the language provided below. And there's some areas of clarity that I think require some discussion. And I think the purpose for this is we're seeing, as we saw with the presentation we had this morning, that there's more and more automated drug delivery systems that are coming, that are going to be made available, and they're not physically located in the location where the drugs are stored. So it's important for the board to know where these are. So if there's some medications that are stored, several miles away, and there's, the board needs to at least be aware of the fact that when there's an inspection or a complaint, we can actually tag it or attach it to that pharmacy so we know who's responsible. I think that's the whole focus for this.
So if it's in a rural area and the rural area is beyond the 75-mile radius, what would be the approach? A waiver or something? I mean, would we be able to give a waiver?
Well, that's a point of discussion. I mean, do we really need to put 75 miles? I think the reason to quantify this is, do you want to have drugs shipped to Arizona? Do you want one location that's going to be supplying drugs through the whole state? Do we want to place some type of limit on that? I mean, 75 may not be the right number.
Within our borders, within the borders of California.
Yeah. That could certainly be. And then it will require that the inventory be done quarterly, which this will be all inventory, not just the controlled substances, Jenny, that we spoke of recently.
That's correct. Right.
So it will require, and when we say inventory, it means reconciliation or just counting numbers?
It means an account.
Just counting the numbers?
Yeah, to make sure you've kind of got it. It doesn't go into the reconciliation where you have to balance it, but if you're doing an inventory, the intent would be is that you'd measure what came in, what went out, what do you have?
So to look any gross errors, so if you...
Right, you're trying to catch whether or not there's a problem with someone pilfering drugs from the unit.
or all the drugs that are stored in there.
For all the drugs that are stored there. And since you're checking it quarterly, that would be about the best, well, that's why it's in there. Whether or not that's a reasonable requirement or not is up to the board.
So in going over the proposal for 4105.5, there is a definition for automated drug delivery system that's in 1261.6A1. Then it also requires that every pharmacy that owns or provides dangerous drugs dispensed through an automated drug delivery system shall provide the board in writing with the location of each device within 30 days of installation or on an annual basis as part of the license renewal. The pharmacy shall also advise the board in writing if the pharmacy discontinues operating an automated drug delivery system. Every pharmacy then, and that is actually on item E, a device used within the licensed hospitals for doses administered in the hospital is exempt from that requirement. It's going to be really difficult in a hospital that operates hundreds of automated dispensing cabinets to keep that up, especially if it's in the hospital setting. C is every pharmacy that uses a system may only do so if all the following conditions are satisfied. 1, the use of the device is consistent with legal requirements. 2, policies and procedures include appropriate security measures and monitoring of inventory to prevent thefts and diversion. And the inventory shall be done at least quarterly. 3, drug losses from the device are reported to the board as required by law. 4, the pharmacy license is in good standing with the board. I think that's really important to have that in there. 5 is device is located within a 75-mile radius of the pharmacy. And that's what we were just discussing as to whether that's the most appropriate radius. D.
I would say it's not.
Remove it completely or up that?
Well, I think it should be within our state borders. I can't imagine something that would be so rural that it wouldn't,
I don't see how it would operate across state lines. It would depend. I don't see how you could ship the drugs into a unit in a different state without there being some kind of a pharmacy license attached to that machine in Arizona or Nevada.
So if there's a pharmacy that's licensed in Arizona, could they ship drugs in a box and ship it to the
Automated
location, to the
device,
automated device, and have somebody there stock it?
I don't believe so. We'd call it a pharmacy in California.
Well, it's a licensed pharmacy. They're in Arizona, and their job is to
California, though.
restock.
But they
they're
can't.
not licensed in California.
We'd have no hold over them. They could ship whatever they wanted in. There would be no control over how it was done unless we have the license. So because the location of the machine would be in California, my first assumption is we would assert that in fact I'm sorry. We would require a license for that.
But they're licensed in California, but they're located in Arizona. Can they ship drug in a box to a nursing unit and have them restocked?
I don't know the answer to that.
So kind of like a mail order pharmacy for automated dispensing cabinets.
If you look, our two supervising inspectors are ignoring us.
I'm just looking
Okay,
at other.
let's
Even
throw a
when they're
question
called
at it.
out, they're ignoring us.
And the other question is,
Janice.
could I have one pharmacy stock all my automated dispensing cabinets for the whole state?
The pharmacy owns the cabinet. That's the one requirement
Right.
here. So
Okay.
it's linked to a specific pharmacy, which is why we want a registration, so that we know who's responsible
Right.
for a machine. So there's no orphan machines
So if I'm,
out
let's
there.
say that in LA County, I'm in LA, I can open a pharmacy whose job it is to restock these machines and have everything shipped out of this one pharmacy. And restocking
So
being done.
Well, maybe,
Why
I
can't we
see where
just
you're
say the
going.
device is located in California? Instead of within a 75-mile radius? So that way, if there's any question, it's
The
done
pharmacy-
No, we don't allow a pharmacy to hire another group to come in and stock their shelves and do that. That becomes the duties of a pharmacy. So if I'm running a pharmacy and I rely on you to come in and restock my shelves and buy drugs for my pharmacy, we would be looking probably at hidden ownership between us.
So you're saying it's not required?
Laura's about to say we're going off bounds here or
No,
something.
I actually think you're in bounds, but what I was gonna say is, you're talking about legislation here, so if there's a practice related to this, for example, if that type of filling of the automated drug delivery system is a problem, then I think you can address that, and you can simply add a provision within this text that would make it match what you think is necessary for consumer protection.
I'm just trying to determine what currently we can do and what we can't before we even look at including it in here. That's why I was
Yeah,
asking
well,
those questions.
let's start with, we want to remove the 75-mile radius, okay? Now, what do we do beyond that point? Do we say in California, or we just remove it altogether? That's the
So
question.
could we say that the pharmacy has to be in California?
We can say that. I think it's superfluous, but we can check. We can add that. No other state's going to let us come in without being licensed in their state. They can ship it in.
That's
to
what I
a
meant.
patient. Janice, could a California pharmacy provide drugs to a nursing home in Arizona without being specifically licensed? They could take care of an individual patient, but they couldn't take care of all the patients.
We actually currently have been asked that question in regards to a lot of the pharmacies that are right on the border of California and Utah and California and Nevada. and- Right, where there's hospitals, and then one hospital is a backup for the other hospital, and they're both in the rural areas. And so the other pharmacy would not be able to send drugs in unless they are licensed in that state.
So it already is within the state boundaries, is what you're saying. You would have to be in that state.
If you're in California and you're going to send drugs to a nursing home in Utah or Nevada, then you would have to have a license in Utah and Nevada in order for you to send it into Utah and Nevada.
As a non-resident pharmacy.
As a non-resident pharmacy.
But Arizona, okay, so if I'm in Arizona and I'm shipping drugs into California,
Same thing.
I
We would
could get a
require-
non-resident pharmacy license and do that.
Correct.
But if you put a machine in Nevada and you want to own it from California, I have no idea if anybody would approve
You would
it.
have to follow what Nevada and Arizona's law allows, because if their law does not allow automated dispensing devices in skilled nursing facilities, you would not be able to do that.
The definition of pharmacy in our law is a California pharmacy unless we otherwise specify it. So when we say in B, every pharmacy that owns or provides dangerous drugs, we mean a California licensed pharmacy.
Couldn't be a non-resident pharmacy?
Mike?
Only if we specify a non-resident pharmacy. Again? Sorry, guys.
So the pharmacy definition in this proposal references only a California pharmacy.
Okay, so then my motion is to remove the 75-mile radius requirement. Do I have a second?
Yes, yes.
Okay.
Yes, you have a second on that, Greg.
Okay.
I think I've been thinking about your comment there, and it opens up a variety of options that I hadn't considered. You know, this might be more of a can of worms than we thought about it. So, yeah, I think removing that's an artificial limit.
Right.
Yeah,
That's
and
true.
so that's a small piece of it. So if you want to get rid of it, that's fine with me.
Thank
So
you.
just go back, so if I can open then a pharmacy, which role is just to restock automated dispensing cabinets throughout the state?
You'd have to own the dispensing cabinets. throughout
Yeah,
the
but I could
state.
own them and I could distribute them throughout the state.
You can do that now without this bill.
Okay.
And the purpose of the 75-mile radius was to ensure that there would be an ability for the pharmacy to monitor, correct?
Right.
So you could, that's another option if you'd like to consider is, I mean, I would assume that this would apply regardless, that the pharmacy, and you would be proving it should there be a violation by expert opinion, but you could also specify in this language that either the PIC or the pharmacy or both must have the ability to appropriately monitor the inventory,
I
if you will.
think
I
that
think
kind of
I
goes
think,
without saying.
Like, yeah, I mean, I think that's
I don't think we need to.
it's existing law.
A lot of it, I think one of the limitations is they're going to have to be appropriately restock the device. So right now, under the law, the only person that can restock a device is the pharmacist, currently, right, Jenny?
That's correct. We've got a
Is that correct? Is just the pharmacist?
allow.
So it would I would have to, if I did this for the whole state, I'd have to have a pharmacist that would go restock it.
Right.
But we also have an amendment pending that would allow a technician under certain circumstances, restoring a provision that was sunsetted some time ago, to do it if you've got a sealed cabinet that's going to go into a skilled nursing facility.
So a pharmacist would have to oversee that technician. So we really have built-in limitations with the fact that they would have to be an employee of that pharmacy to be
Right.
able to do this. Correct? I'm looking at our inspectors, yes? Now, from an inspection standpoint, what is your thoughts on this regulation?
Okay, currently under Health and Safety Code 1261.6, it does state that a pharmacist shall restock it. It does also state, though, if the device has removable pockets, and you can remove those pockets, send it to, or drawers, to the pharmacy, it could be restocked in the pharmacy by a pharmacist, technician, or intern. But however, it is gray, in which it's silent as to saying who else, other than policies and procedures, who can stock it. So currently, the only thing that it does clearly address is a pharmacist shall restock it. Sorry, what was the other question here?
Is there anything else in here that you believe
The
should be-
75-mile radius. With most of the long-term care pharmacies, their intent really is to put these into locations that are distant. And so to limit it to 75 miles would restrict where they can place it, where it's really intended for, to provide better service. So when it's farther, because of the mandate under Title 22, where they have to provide certain drugs within an hour from the time it's prescribed versus 4 hours from the time it's prescribed, pharmacies that are located farther than that, it restricts who they can market as their customers. So my understanding, again, is the intent is to place them in the more rural areas or nursing homes that are farther from the pharmacy.
Now, in describing an automated drug delivery system, we're not just talking about automated cabinets in long-term care facilities, are we?
No, we're talking, there's a definition, I think, at the bottom of this, isn't
So there's this could also apply to the pilot
Yes.
we heard this morning.
Yes.
So it's not going to only,
That's the plan.
I said that if it's not going to only apply to skilled nursing facilities, it'll apply to any
Right.
remote automated dispensing cabinets. When we think
And
about
as
this, we need to consider, there's certain limitations because you have to restock it. So you have to be close enough. That's actually a limitation right there.
I
from a
think
geographical.
the proposed regulation states any automated dispensing devices that a pharmacy is maintaining. So it would be a ads machine in a nursing home, an ads machine in the hospital, but I think in the hospital one, they want it to be exempt from registration because it's all in that one location. Now, the question though is we've been hearing that there's automated dispensing devices beyond the building of the hospital. So that would be a concern because if it's going to a different building or a different, someplace that is a mile away or even if it's down the street, again, it's outside that address of record of the pharmacy. So I would be concerned about, I would require registration on those. The other concern that we were talking about, Christine and I were talking about, is whether these automated dispensing devices, once they leave the address of the pharmacy, now if you contain controlled substances in there, the requirement if they need to be registered with DEA. Because DEA currently requires, if you're putting an automated dispensing device in a nursing home, you have to be registered, that location has to be registered with them. But we're finding devices beyond the nursing homes that are not registered with DEA.
Right, but my comment was that it's not just, we're not just talking about automated cabinets that a nurse would access.
Right.
We're talking about things, automated devices that a patient could access too. just as the Asteris machine we were talking about this morning. So that's why I was asking for the clarification of what is actually referred to as an automated drug delivery system.
It actually refers to the following. For purposes of this section, an automated drug delivery system means a mechanical system that performs operations or activities other than compounding or administration relative to the storage, dispensing, or distribution of drugs. An automated drug delivery system shall collect, control, and maintain all transaction information to accurately track the movement of drugs into and out of the system for security, accuracy, and accountability. And that's the reference where it says to 1261.6A1. That's what I just read.
Right, so when we think about this, it's very global.
Yeah.
It's not just the nursing homes, and we're thinking about anything.
Right.
So having even a Asteris machine somewhere, or one of these machines where a patient could pick it up. So as long as I could restock it, you could actually link it, but the board would at least know where it was.
Right now, we have no knowledge about where these are, and we know that they're being used in prisons as well, or jails, and we don't know where those are, or even the fact that pharmacies are dispensing medication into these machines. So this is just an attempt to identify where the drugs are being stored and provided where there's patient access in some fashion.
And I think the comment about the hospitals, I think we need to understand what's under the consolidated hospital license, because if it is part of the hospital grounds, wouldn't it still be under the hospital? So maybe those that are in the audience that are from hospitals can help us with item E on how to best clarify that.
Well, there's been a group of the supervisors who are undergoing that as a project, where we're trying to identify all the locations where we're finding these automated dispensing devices, and then working with CDPH to determine what authority these locations are allowed to have these devices, and if they're not allowed, if these are locations that need to be licensed and registered.
As part of the hospital? Because my concern is, I understand that the inspectors have been recommending that some hospitals open up retail pharmacy licenses when they're operating part of the hospital that's not on the physical ground. And that if it's part of the hospital and they're servicing patients that are admitted to that hospital and they're part of the consolidated hospital license, they probably should be treated, as a hospital. Unless there's a reason why we're asking them to open up retail licenses.
No, we've already kind of resolved that particular issue. And we have a meeting planned where we're going to go back and identify where we have done that and modify it. It'll be easy for us, I think, to do, to make sure that we've got a smooth hospital, campus type environment. But there are still some clinics where we're seeing drugs being shipped into them, and we're not sure how some of that's being done. But that's not related to these vending machines, or I called it a vending machine, the automated machine. That's another piece of the drug distribution within a hospital that we really haven't paid much attention to over the last few years. For example, I've got a file that we've got a hospital pharmacy that shipped a bunch of drug to a clinic, and they didn't appropriately store it. They provided it to the patient. We don't have any control over the clinic, and yet the patients were harmed.
Was the clinic part of the hospital license?
It was part of the consolidated license, but there was no pharmacy premises or no drug storage premises in that clinic, and they had been storing the drug for a period of time. So it was a clinic, but it wasn't a licensed clinic. So these are some of the issues we're grappling with as we deal with this, but any second now I'm about to have our attorney cut us off because I'm gone way off subject. But the goal is, this is one of the issues related to the drug distribution in hospitals.
Well, it's related, to drug distributions, but it's related to the topic too, because essentially these machines may be serving as a pharmacy in a certain way, and so the address of the facility, the address of the outpatient buildings. I mean, this is pretty important stuff, and there's been some serious modifications that have been regulatorily mandated, and I'm not sure if they're promoting the health of and welfare of the people of California. So I think we should follow up on this and get some reports from the from the field and what's being done out there and how it's defined. I can see pushback from the hospitals, justly so, because these areas are integral to their function, and if we're requiring undue regulatory compliance, the people of California aren't being served as they should be. So this is very concerning.
So where within this regulation are we interfering there? Because I think this is a statute that's going through the Capitol right now. And if we need to remove that, I think we need to address that right now.
I think what Alan's referring to is item E, how that is going to be defined and interpreted, whether do we need to elaborate on item E. So a device used in a licensed hospital for doses administered in the hospital is exempt from subdivision B. So how are we defining that? I think that's where you're getting at.
Oh, sorry. So I think the only thing that you have a very broad agenda item here, so you can talk about anything that has to do with the registration of an automatic drug delivery system for dispensing of medication. So I'm not worried about that. But you do have a motion that's very specific to one item. So you may want to resolve that particular item and then move on to the more global discussion.
Thank you.
All right, so Greg, your motion is to remove C5.
Yes.
What comment?
Okay, is there a second? So you had a second
I had a
already.
second.
That's right.
Weren't you paying
Public comment on removal. We're talking specifically about removal of C5, about the 75-mile radius. Good morning, Lynn.
Lynn Paulson. I was thinking that the 75-mile radius would be sort of moot because we already have the wholesalers providing a box of drugs for a specific fill of a Pyxis machine. So they are already doing that. So at the very least, these pharmacies that want to do that could register as a wholesaler, and then there'd be no 75-mile radius, right?
We're not going to let a licensed pharmacy hold in the same premises a wholesaler permit. We won't let that occur.
Right, but you
Or
could
just
have,
switch.
but I think you could have a business, right? I'm not going to have the business, but somebody could, where they purchase drugs as a wholesaler and turn around and sell it to hospitals for specific Pyxis machines. I mean, that's what they do already, so.
And not have the pharmacist required to restock it.
Well,
Yeah.
So you're
there's a
supportive
provision that
of
allows
getting
techs
rid
to do
of
it.
it?
in the hospital.
You're supportive of getting rid of the,
Yeah, I mean, I think it's, there's a way around it already, so it doesn't make any sense to have a 75-mile radius. And a lot of times, it seems to me in general, these mile radiuses tend to be more left over from the East Coast rather than the West Coast, because we got wide open spaces. And so I think that they're all arbitrary and sort of serve no function. But I think even if you left it in, there'd be ways to get around that pretty easily.
Thank
Well,
you,
it
Lynn.
restricts patient care in a manner, and this would apply to any pharmacy that provides services to a machine, not just a hospital.
Right.
So I'm not, 75 miles is pretty arbitrary, and you're right,
Yes.
wide open spaces.
Yeah, especially in rural
Plus,
areas, as
with-
Greg pointed
Yeah.
out.
what Janice said, that, the intent really is to be able to provide the service to outlying areas. Why put a limit on it?
So
Sure.
I would agree with that.
It seems to
you.
be a little bit overreaching. If once we do a registration and it appears that we've got a problem right around 75 miles, we can bring that back with some data to the board instead of just guessing where do we need to draw some kind of artificial boundary.
5 miles and
Nothing.
5 miles and.
And then as the crows fly or as the road goes.
And what's the right number, 75, 80, 100? It's very arbitrary. Good morning, Rita.
Hi. So another way of thinking about this is if a hospital under its consolidated license has a clinic that is somewhere, And that clinic then needs to be licensed with the state board if there's not an on-site pharmacy. And that clinic then has a physician oversight who's responsible for ordering medications for the controlled substance. The pharmacy department still has to have some sort of arrangement, like kind of like a AKA consultant pharmacist arrangement, to ensure the accountability and integrity of the medications that are being utilized there by at least, a once-a-month evaluation. Would that meet the...
Quarterly.
Oh, I thought, well, see.
Oh, you're going above.
Nah,
Yeah, of course.
That's because the hospitals are once a month.
But anyway, would that be kind of the way this would play out to ensure that there was oversight of that particular automated dispensing machine?
Well, the goal is to have the pharmacy provide some oversight at
Right.
least quarterly in the
Okay.
event, and most of you are probably doing that, like you said, at least quarterly.
Yeah.
So it's just meant to ensure that there's some review, that the machine doesn't get put out there,
Right.
and you have
But it's just
expiration date issues and all kinds of other things that will be going on.
Okay, so whether it's 75, the 75 miles aside, the same level of oversight needs to occur for whatever machine is within the licensed space. Now, there's also the unlicensed space issues, which is beyond the scope
But
of this
that's not
discussion.
part- yeah.
No, I understand.
Yeah.
Good input, thank you.
Any other public comment? Okay, all those in favor of the motion? Greg, you're batting 100 today. All right, so the remainder of the proposal, are there any other changes that we would like to have made to this before we take it to the board?
I would recommend that you define what good standing means to you, because good standing.
point.
Can mean have a license that's not expired, or it can mean have a license that's not restricted. So you want to be
We say
specific about
unrestricted
that.
license?
Is that the term of art that's preferred?
Well, I would say, I would probably go beyond if what you're looking for is
Active and
not,
unrestricted?
not on a disciplinary, not under disciplinary conditions. Is that what you want?
Is that what is that what we should write?
Well, it depends on what you want. So.
Not under disciplinary, any disciplinary actions that are, that have been enacted, so an unrestricted,
Yes,
non-probation.
Right. Not on disciplinary probation.
You
'cause
should
could
also
have-
say active, so it's not expired.
Yes, well,
So say
presumably.
active and not under
Presumably, they couldn't be
discipline.
doing it if they were expired, which is one of the reasons that good standing raises the question. But, yeah, but we can say active, unexpired, and not on probation.
So active, not expired, and not on probation?
Yeah.
What's the difference between active and not expired?
I think it could just
You
be
can
active
have an
and-
active, you know what, it doesn't apply for a pharmacy because it would, that language is generally applied to individual licenses where they can go inactive.
Oh, yeah, you could, right.
So it would be an
right.
an
I'm blending
unexpired
my
license,
license
not on
types.
disciplinary status.
Right.
And just to clarify, the only section that we're exempting licensed hospitals for is the registration section. The rest of them
Is
will
the
be
E.
the same, yeah. Okay, just to clarify. Okay, any other changes? Alan, are you okay with this? Greg, you okay with the rest of it? Sorry, Alan, why didn't you make a motion this time?
No, I want Greg to be the king today.
He's batting it.
Oh, I know it, it's good for his ego, he needs it.
I'm always the
He needs it.
motion
I don't
person.
need it. He
All right,
needs it.
Greg.
So it's my motion?
Yes,
All
I
right,
guess.
so moved,
To,
whatever it was we
now,
just finished
since
saying.
this is legislation,
Yeah,
law, is-
active, okay, that it be active, unexpired, and not under disciplinary action.
I think we decided you don't
And-
need the active.
Yeah, it would be
an individual
an
license.
unexpired license, not on disciplinary status.
Okay.
unexpired, and not on probation or not on disciplinary?
Dis-
Not
disciplinary
on-
status would be
Not
on
on
probation.
disciplinary status.
Okay.
It wouldn't include citations and fines, it would
What if
only be,
it's pending discipline?
it's not on disciplinary status.
Okay. Status.
You can't prevent them from doing it if we just charge something.
How about we say not subject to disciplinary conditions?
That's fine.
Not subject to
I'll accept
disciplinary
that.
conditions. You accept that amendment, Greg? Okay, so is your motion to modify or the section
Last time I said I do, I got in trouble.
C4, or are you talking about the whole regulation with those changes?
I'm talking about this section.
Okay, so C4. Is there a second?
Second.
All right, public comment. All in favor? Oh, wait, there's a public comment, sorry.
Okay.
Okay, now this is in reference to C4, which is the definition of the pharmacy license. No?
Okay.
Okay, no public comment
But it's
on
good to
that.
know that you're here.
You may stick around because you know what's coming
wait.
next.
Okay, let's
Okay,
vote. Let's
any
vote.
public comment on C4 definition of license? Okay, all in favor?
Yes.
All right, now, since this
Don't have
is,
to get violent.
well, since this is legislation, does this now go to the full board? Is that how this works, to July meeting?
Yes, the full board should be approving any revised language. One final comment that might be worthwhile based on the last thing that you had mentioned, President Gutierrez, is that under sub E, it says a device used in a licensed hospital for doses administered in the hospital exempt from subdivision B. Do you want to specify exempt from registration requirements of subdivision B? Just to make it clear that really it's the registration requirements that you're
Okay, and should
exempting
we,
it from.
instead of device, should we also say automated drug delivery system, or does that
Yes.
matter?
A device gets there, though.
Oh, includes a device. Okay, I'm just wondering, because we say an automated drug delivery system includes a device as defined. So is the word device okay, or should we?
I think you're right. I think automatic drug delivery system is the broader.
An automated
because
drug
that's what you're
delivery
defining in
system?
We're using system throughout the rest of the reg.
So it's an automated drug delivery system used in a licensed hospital for doses administered in the hospital is exempt from the registration requirements from subdivision B.
And Ginny had mentioned that we do use the word just simply system, which would also be okay.
The system?
Whatever, in this case, Ledge Council's going to have its way with the language anyway, it doesn't matter.
Okay, so we just leave it system to keep it
Yeah, let
simple?
them, they'll make it consistent.
And let them?
Yeah, they'll fix it if they don't like it.
Okay, Greg, you good for that motion? Second? Any public comment on the changes to E? Okay, all in favor? All right, so then the next one is approval or forwarding the final proposal to the board at the July meeting with the revised changes we've just approved.
Got it.
Want to move on that one?
No, I want Greg.
Oh, Greg, okay, Greg?
So moved.
Second, okay, now any public comment on the full proposal? Do you have one, Doug? I thought that's what you were coming up for before.
I got confused about which section.
Do you want to make sure your microphone's on?
Hi, I'm Doug O'Brien from Kaiser Permanente.
And Lori Hensick from Kaiser Permanente.
Double
So
barrel
I think
Kaiser.
Dr. Shad was referring to, this can get sort of confusing. So an example would be the California Department of Public Health hospital license, so consolidated license. And then there's frequently hospitals, when they undergo their Joint Commission survey, expand what gets surveyed to areas that perform procedural sedation. So for instance, a good example of that oftentimes is a GI lab where they do procedures and they sedate patients. So when you have the Joint Commission survey, you have them accredit all of those areas, the California Department of Public Health licensed areas, as well as that GI lab, which is not on the California hospital license, but they perform procedural sedation there. So generally speaking, we have the same level of drug control in all of those areas, which usually means that we have a Pyxis machine in that GI lab. So it's not part of the hospital. So, and the reason I bring that up as an example is it would be confusing the way this regulation is written. So the Pyxis units inside the hospital would be exempt from registration but that one sitting out in the GI lab, which is not part of the CDPH license, would have to be registered. So it could get very confusing, and I see the inspectors shaking their head because they're seeing this out in the field. Sort of having that configuration leads to better drug control, better quality, better patient safety, and protection, public protection. But it gets confusing as far as when you start to do laws like this.
Isn't the GI lab considered part of the hospital, even if it's not part of the
Not
license?
part of the California Department of Public Health hospital license.
Not part of the
Yeah,
license.
but
it's
it will
part
be
of
on, it will be
physical
on the hospital's
premises.
Joint Commission accreditation, which is
Right.
what Dr. Shad was referring to. So what I would say is it could get very confusing. And so, for instance, and I don't know what the word inventory here means. If inventory means physical count, I got to go open up the machine and count everything, or if it means I can spit out a report from the machine, and that's my inventory, because that makes a huge difference, as you look at this. So I think the previous regulation you were talking about, there was not going to have to be a physical count of these hospital Pyxis units. There was going to have to be a physical count of everything inside the pharmacy.
Right.
So in this case, you would have to, if that means physical count, go out and count the machine in the GI lab, but your other 120 machines in the hospital are
Yeah,
exempt.
What you're bringing up is something I was talking with Ginny about earlier, as far as the need for a manual count when you have the
Yeah.
information within the machine, and
That's right.
it doesn't make sense to do that.
Well, I think that was part of the point of other comments that were submitted about the last regulation, is that if we have essentially a perpetual inventory with discrepancy monitoring, as Rita Shane said,
Guess the only
do you have to
question-
actually go out and physically count it?
The only question would be, could somebody who knows a lot about computers and so on rig the system so it would report something that isn't in it?
Yeah, you can take out more drug than you need, for example.
Well, it's usually detected, though, because if you have a blind count, it means, let's say you go into the system, Greg, and you say, it tells you how many are in there.
Right.
And you say 10, and let's say you take out 2. And if I go in there after you, and it says how many are in there, and I put 8, and you said you removed 1, it's going to signal a discrepancy. So you actually have ongoing counts that are going on, and they're blind
No,
counts.
I understand that. The only question is, well, all I'm saying is, could somebody rig it so it says that there's 8 in there when there's 4? You call out a report, an inventory report from the machine itself. Could that happen?
Yeah, well, I mean, if you were stocking the machine, you could do funny business with that. But the next person that opened the machine, and if you use blind count, which we use
Somebody
on all
would
of our
find-
machines,
they would
you would
find out
discover
at
it
that
right
point.
away. It would create a discrepancy, and then that has to be resolved. So
Unless
yeah.
it's a rarely used drug, and let's say the time period between you and me is several months or a month, you wouldn't identify that loss for a while.
Right.
That would be
So
another
without
issue.
physically counting what's in there, you wouldn't know, but it's
Yeah.
pretty rare.
So most facilities have a standard about they physically count every so often to prevent what you just described, which is pockets that
Yeah,
are not.
I think
Yeah.
if it's done periodically.
Yeah.
What's your policy on physically counting right now on your automated cabinets? How often?
So currently in our hospitals in Northern California, we count once a day, physically.
Once a day?
Once a day.
Even in a GI lab, you'd count once a day?
We do.
But not in the machine.
Yeah. in the
Yeah.
machine.
You
No,
do.
that's what we're talking about, yeah.
It's not the pharmacy counting, it's nursing that's counting. So,
So doing at least quarterly, would that be a problem if you're counting every day?
well, it's to. Yeah.
Correct.
Yeah. So I think, the issue about counting physically counting narcotics is if you don't access things a lot, it's a good idea. If you're accessing stuff every day and you have people in there every day, blind counts, you have discrepancy resolution and discrepancy creation. You don't have to count very often because you discover things right away. So it's a whole process of oversight of the machines as you've described before. I guess my other question about this, so I think Section E is going to be difficult because of what I just described about these areas that are non-licensed. And I think when you say licensed, you're talking about California Department of Public Health hospital license, right? Yeah, versus areas that have machines and are oversighted the same way that are Joint Commission accredited because they're procedural sedation sites. That's
Do you have a
confusing.
recommendation as to wording that would work?
Well, I guess you could say licensed or, number E, you could say licensed or accredited by Joint Commission, something like that, as number E.
Not all hospitals use Joint Commission.
Right.
Oh, right, well, I mean, you could say.
Licensed or accredited?
American Osteopathic Association, there's a couple of accrediting agencies, right? Joint
No.
Commission's 90%.
I think that's going to be pretty nebulous for the inspectors to figure out
Okay.
as well.
Oh, inspectors.
What do you
do you have any
recommend, inspectors?
suggestions?
I know what you're going to say. Go ahead.
We're actually having a debate over here about the term licensed hospital. If the understanding is licensed hospital is the CDPH license, that changes how we would enforce it. If the term licensed hospital is the Board of Pharmacy licensed entity address, that's going to change the scope differently. So Jenny's shaking her head, it's a CDPH
It can't,
license.
it's got to be the CDPH, because they're talking about a consolidated license where they, on a campus, they're going to have machines all over. They're not talking about the main hospital building where the pharmacy's located.
They're also talking about adding in other areas that are not CDPH licensed, that are part of their accreditation visit, but are not part of the consolidated hospital license. So we're talking
example,
about
the GI
different
lab.
scopes here. We're moving from the Board of Pharmacy to the CDPH to now expanding it to accredited areas.
Right, and then we're also looking at the wording administered in the hospital, because, again, the whole intent is so that we know where all these locations are. Once you leave the building of the hospital, we have no idea where all these machines are.
Can we say in
So,
the physical
I thought the
location of the
intent-
hospital, or
I'm sorry?
can we make it in the physical?
Well, I think the problem that we run into,
hospital.
Greg, the problem we
Yeah.
run into is that up to now, it's been licensed as the physical address of the hospital. So hospitals have campuses. So if you're like a little ways away, you're still part of the CDPH, it may be you just walk out a walkway and you go into another building. The board's been considering that not a part of the hospital.
Well,
So
can we
you
say
run into a lot of
within
issues
the
with that.
premises and define premises as including the campus?
But what we're hearing now is we've got a whole new definition of premises, which means these buildings that are not part of the consolidated license, but they're sitting over there in a garage or somewhere else that aren't part of the consolidated license.
So let me
And
ask-
I don't know how we define it with the specificity
Let
we
me
need.
ask Doug, when you restock those machines with narcotics, are you stocking them with hospital narcotics without a DEA license and?
No, so if that GI lab is I was just going to bring up the next level of complexity just so that you know what actually happens. But if that GI laboratory where this thing is happening is a doctor's office, okay, you have to transfer those
222
narcotics
forms,
via
yeah.
222.
Right.
And basically now the physician owns that inventory. And you are helping to oversight that and make sure that, bad things don't happen to it. But it's really the physician's drugs.
So if the physician owns the inventory, I don't think the purpose of this is to talk about physician-owned inventory. I think the purpose of this is just to look at inventory that the pharmacy controls. Because
Okay.
everything inside of Pix's cabinet is still pharmacy inventory until it goes out to the patient or it's transferred to a physician.
That is correct.
Oversight. So in terms of definition of a hospital under pharmacy control, what would you recommend? That's why we were kind of looking at the consolidated hospital licenses, the definition.
Well, if you're okay with that, I just wanted you to know that there are these automated dispensing machines that will be oversighted by a pharmacy, but the inventory in there is actually owned by the physician. So if you don't have any oversight over that or don't care about those, that's okay with me. Then I'm good with the consolidated hospital license,
Then it probably works.
Yeah, yeah. I mean, that's okay with me. I mean, if it's outside your purview,
Yeah.
I don't think we have purview over physician-owned
No.
stock, do we? Unless they're a licensed permit, And it's the Board of Pharmacy clinic permit?
Well, the physician can only own drug stock in a vending machine if he or she is using that machine to take care of his or her own patients. They can't have it for a clinic, and so.
Correct.
Unless they have a clinic permit.
Sure.
So that physician-owned set of drugs is very specific to who can access it. So if you've got multiple prescribers using it, it's a violation of the law, and it's probably a violation of our law. I don't know who else's
No, I
law,
mean,
but
I
the
understand that.
4170 is the code section that
What I'm
deals
saying is,
with
when
prescriber dispensing.
when your inspectors come and look at, so if you come to one of our inpatient pharmacies and say, tell me where all your, about all your Pyxis machines, they'll hear about these. So, I mean, I'm just saying that's the complication.
Well, and I think that's what we're trying to get at. We want to know where the machines are.
Okay, well,
Well, he's saying like
but you
in a
don't want to know where that
GI.
machine is.
Owned machines that are overseen by a physician.
If they're owned by a physician, they drop out of the definition earlier on where they're talking about the
Let's-
pharmacy owns the,
I don't think we want to comment.
Let's
owns
talk
or
about his
provides
specific.
dangerous drugs dispensed.
So
There-
Kaiser
sorry.
makes it a little more difficult.
Yeah, they sure do.
And so for most hospitals, we would not be transferring hospital-purchased product to a physician office. So they're a little different.
We're a little different.
Because they're a little different. But, I mean, in a good way.
And they enjoy it too, look at that.
Yeah.
Different but equal.
Anyway, a hospital, I mean, the first thing you should do when you walk in the door is to ask them for a list of all their Pyxis machines, which.
That's what we were asking for here. That's really all this
I
really
understand what you're
initially
saying.
intended to do.
So I would say you want to ask for all the Pyxis machines on the consolidated license. For machines not on the consolidated license that are owned
Owned or
by the
provided dangerous
the-
drugs by the pharmacy.
by the pharmacy, then those probably should be registered in a different manner. But he's got a worse problem because they're sort of still owned by Kaiser, right?
Yeah,
So it's messier. But for everybody else, you can't take your hospital drugs and put them in a non-hospital Pyxis machine. So usually you buy drugs specifically for that clinic on a separate account and bill it for that machine. So that's a different setup, and it's sort of like a separate clinic license. So that could have a different view. But the pharmacies, I mean, we have to go fill those machines day and night. We know where they are.
so they're helping to oversight the machines too. So
Yeah.
different sort of way about how the drugs are supplied, but you oversight the machine.
Yeah.
The other question I had was section E, where it says it's exempt from subdivision B, which is the registration part, right?
Yes.
Okay.
We just clarified it with
So
the
the-
registration requirements
Registration portion.
of.
So does
portion
that
B.
mean the hospitals are not exempt from section C, which is the inventory part?
That's what it would mean.
That's what it would mean.
Okay, so all of the Pyxis units in the hospital now then have to have an inventory done at least quarterly on the drugs?
But they don't have to register and tell us where they are, you just have to do it.
They don't have to register, but then the controlled substances,
Right.
didn't we exempt the inpatient Pyxis machines from a inventory? Didn't we just do that in the other regulation?
I'm wondering if we could use that section H from the other regulation where it says that the pharmacist in charge shall ensure that, and instead of just for controlled substances, just for general inventory, to fulfill the inventory requirement. Because if they are doing regular blind counts and they are doing tracking, that's just as good as counting the inventory, really. I'm just wondering if we
I
can
like
just
that
put that
better.
in there. Because that is a lot
Yeah,
to, in
because
a hospital with 100
as written, these two things
machines.
then would seem to conflict with me, the last regulation and this regulation, just because of.
The only ones I think that we have to be careful about are, there's this ability to only count the ones that have been accessed since the last checked period of time. So if you do that, so let's say you have a weird and obscure narcotic in a Pyxis machine that probably doesn't belong there. And it goes months in between use, right? So that's never going to be counted because people have their machines set up so that you only count it if somebody's used it since the last count. So that would be great, except for the same 2 keys open the back of every Pyxis machine.
And there's
entry.
another issue.
Well, I think what in the previous, are you talking about the previous regulation? Because the previous regulation says all Schedule 2.
Right.
So it doesn't regardless of whether there's been movement or not, you're going to count all Schedule 2. What I'm proposing for this regulation is just to look at the whole inventory portion to mirror the inventory portion we had in the other one.
Right.
That's
But-
what the only
but I think
recommendation.
that somehow, there has to be some clarification, because I think there are people who are confused about the manufacturers of the machine and to tout this as a process. So if you ask people, how often do you count your machines? Oh, every day, every shift, whatever, except for they don't really mean that. They mean except for the ones that we didn't touch since the last time we counted. So it has to be all narcotics without exception, all C2s without exception.
So, I mean, I think that other language would work well in there.
Yeah.
And just so that, you, and I'm sure you probably know this, but the hospital consolidated license, I mean, depending on when and who you talk to at the Department of Public Health, I mean, buildings can be up to 25 miles apart and still be on the same consolidated hospital license. So
You can
it would be a
have
different
two
physical
big-
address and, you know, that kind of thing.
Big hospitals on the same consolidated
You can't have
license.
that. That is very true.
And they're all under the control of the inpatient pharmacy. If
That is
they're-
correct.
If they're on the consolidated hospital license. So it would be that one pharmacy.
Mm-hmm.
So the creation of another pharmacy just because it has a different address doesn't make sense, at least from what I
Well, let's see. Now,
No, we have to have
we.
separate
Yeah,
licenses.
we do
for-
have those actually in some of our
for-
places, so.
Well, if it's 25 miles apart, I can see that. But if it's just down the street or within a short block on the same
Yeah, I mean,
campus.
I would defer to, you know, the board executive officer and staff about how they assign the different licenses. I just know that we have on the consolidated hospital license, same CDPH license, we have more than one inpatient pharmacy license in some of those areas. Maybe historical, maybe not.
That complicates
But
it further.
what we've had, what we've been required at all of our facilities is to have one pharmacy license per physical address. And so where we get questions are when we don't actually have a pharmacy in a building, what do we do then, right? But we have Pyxis machines, but we don't have a pharmacy. So those are the open questions. But no, if there's an infusion center on the consolidated license, but it's across the street or down the block, those all have been required to have separate licenses and separate PICs, which is really the challenge, is because each PIC can only have 2 licenses, right? So then you,
And these are inpatient licenses or outpatient? The infusion centers?
the infusion centers are probably outpatient licenses. But we have 2 inpatient licenses in San Francisco, 2 in,
You-
3 in San Francisco, excuse me.
Well, hopefully it didn't make it more confusing, but thanks.
Yeah, I'm just going to end with saying, and I think Doug already summarized it, but just to reiterate the fact that we fully support and encourage the board to actually mirror the language as much as possible, considering the amount of work that went into the rewriting of the other regulation that has now clarified and detailed what is required. And since it's basically the same inventory type of requirement that's being set, that it would be easiest and probably less confusing if we could mirror that as much as possible. So thank you.
Makes sense.
And then my only other suggestion would be, given the fact that this is pretty confusing based on the differences in some of the consolidated licenses, I wonder if this might be helpful to I don't want to delay anything any further, but I don't know if there might be a short-lived task force or some sort of other way that some of these organizations, larger organizations with more complex matters, might be able to provide some feedback in a different manner. So, thank you. Good morning.
Make my comments short. I'm Jeff Nahara from Mercy General Hospital, Dignity Health in Sacramento. I just want to kind of agree with that statement. What you said, Amy, regarding consolidating the language is definitely appreciated, and I definitely agree with. Just to let you know, for a lot of the hospitals that exist in California today, a lot of them are old hospitals. My hospital is 92 years old, and we're made up of several different buildings that have been there for quite some time. So to have a separate pharmacy license, like you're saying, for those 3 different buildings that are actually interconnected. There's bridges and walkways between these buildings. I mean, you can't even tell you're leaving the building.
And you have
most of the
different
time.
licenses for every section?
We don't. We all fall under the one license. And to try to register each time for a different pharmacy license would be very, very complex. So I just wanted to make that comment. So thank you.
Thank you. So can I recommend to board member, oh, I'm sorry, Laura, did you?
Well, no, I think you finished, and maybe I can offer help.
Okay, well, I was going to recommend is if we can deal with the inventory language and revise it and work with you to bring it before the board if that's what the board members wanted, but.
Yeah, I think it could be done really simply, which is to say the inventory shall be done consistent with the board's regulations. And then any regulations that you have on the subject will.
Because the regulations we have are related to controlled substances. Now, my understanding when I asked Jenny at the beginning, this is for all drugs, not just controlled, is what
It's for all drugs the way it's worded, but you can restrict it so that it focuses on, again, keep in mind, some of these units are out in the middle of nowhere, and we want to know when drugs start disappearing out of them, regardless of whether or not they're controlled or not. The controlled are the hypersensitive group, but I think we need to know if we've got a machine stain out there that kids are getting into for whatever reason. I think
Antibiotics or something.
well, there's other drugs that you can get buzzed from that aren't controlled drugs. And who knows what's going to happen with these machines if they're out there too far. The goal is that these machines are showing up in places where 5 years ago they wouldn't have appeared. And so we just want to know what pharmacies are servicing them so that when we encounter a machine, we know who's responsible for it. That's what it started as. And then the board wanted to, make sure that we had security, like accountability and some inventory stuff. The concern I've got, this is one of our sunset recommendations. We are now into the second House deadline. We are literally going to have to be in the House of Origin deadline by the end of the week. So this then means our sunset bill is going to go into the Assembly, if it hasn't already, and I truly don't know. I was just looking at it. This provision is not in there. So if the board is going to work through this, we're going to have to take a bill next year because I don't see how we're going to get this through. The board meeting is the end of July. That comes after the policy deadline for bills with fiscal impact. We're not going to want to hold the sunset bill to do this, which means we're going to lose the legislative impetus that what we've had here. Now, the board, I don't know whether or not they ever approved this moving forward. We had an approval early on as a sunset recommendation to do an inventory list of all machines linked to a particular pharmacy, which is where we started. We now want to include, as part of that inventory, a requirement or a part of that registration that there be an inventory component to it too. If we're going to keep those two pieces together, I think we need to recognize we're not going to make the legislative deadlines for this year, and we're going to lose the registration requirement.
So can I ask then, if we take out the part where it says the inventory shall be done at least quarterly, because right before that, we do say policies and procedures include appropriate security measures and monitoring of the inventory. If we just took out the inventory, would that meet the whole focus and keep us on time?
I think it allows the board to address how it's going to deal with the inventory requirements somewhere else, which is kind of what I'm hearing.
Right. Okay, so I'm trying to find a way to resolve this issue.
No, that's why I'm throwing it out there now.
So, because the inventory quarterly is kind of an arbitrary thing we just added in there. And the previous sentence does actually, that actually requires the pharmacy to develop policies and procedures on how they're going to monitor the inventory, which is what we want. And it may be what may be appropriate for one pharmacy or location, may be not the same as another. So this will allow that freedom for the pharmacy to do that.
Good point.
So will that resolve these concerns about modifying all the inventory language? But it doesn't resolve this July board approval timeline that you just cited.
No, that would be the president and vice president have the ability to modify the language.
So we can do that.
You would have to do that separate from this meeting.
Okay, and then we could still meet that timeline?
Then it goes back to the board in July, and any final cleanups could perhaps be done, because then we're looking at the fiscal deadline in August. I don't remember when they go on vacation, but probably at the end of July, they're either halfway through their vacation or they're just coming back from their
Well, if
vacation.
we remove the sentence, it makes
If
this
we
work.
just go back to the streamlined model we had initially, it solves the problem.
With the changes we just made? With the few, because we did make some changes about the 75-mile.
We're taking that out, which is one of the things we stuck in.
And we did say the registration
We're
requirement.
defining
E.
what active and good standing means.
So you're
and
saying
E-
that if we took, because we removed C5, we modified E, and if we take out the underlying section of C2 about the inventory quarterly,
Yeah, the only issue is whether it does not exempt hospitals, because the initial proposal did not. That's down in
right,
E.
but hospitals could still have policy and procedures to include appropriate security measures and monitoring of the inventory.
s-
That would be the remote monitoring that they've got in
So
place.
literally go back to the version that came to the board without the additions that are underscored here.
Without the addition of the underscore in C2, because we did take out C5.
Five.
And we did modify E. Would that work? And then we also defined C4, which is the pharmacy license in good standing. We did make that modification.
You can vote on this right now, then I'll go back through the minutes and see whether or not we have approved this language before with modifications, because that's what I
Okay.
need to check.
So do we need to roll back what we've done and go back to, or do we just now?
Well, you
One
took out the
sentence.
75 miles, so you already took out, if you
Right.
notice, 5 is underscored. Dr. Gutierrez is proposing to remove the underscore on C2,
Right.
which was another addition. And then on E, we've added in, we've defined what in good standing means, right?
Or C4.
C4.
Oh, C4, okay. And
E
then-
is when we said that the device, the registration requirement for hospitals.
Okay.
So is
That
is
one
that
is-
enough of
I don't know about E, but the rest of it you guys have, I think have approved. Because when we did the sunset review, it seemed to me that we approved that back in December or October when we brought the whole proposal
Oh,
to you.
it-
But I need to go check that, I don't
Right,
know.
but if the board amended the language since then you have to kind of deal with that
The board
issue.
hasn't amended it, and this is not yet in the bill. It either goes into the bill or it doesn't.
Okay. There may be an opportunity to do a special meeting in conjunction with your board meeting next week, just for this item if you want. That's a possibility because it's legislation.
That would be
So
good if we
can
could
look
do
at
that. If we can do that, that
That may
solves the problem,
solve
and I
your
can just
problem.
be quiet.
Yeah.
and
That'd
not-
be great, even though
'Cause
we
it's
haven't
legislation.
agendized
That
it.
allows this committee to finish.
There's an exception to the 10-day requirement for the Open Meeting Act if it's legislation, and if you're trying to act on legislation, I'll need to double-check to make sure that this qualifies. I think it would, though, based on the description and the fact that the board has already, you have a bill that you're talking about here. I think that we might be able to do it that way.
Great,
So
okay.
instead of using the
Let's go back and
president.
fix E.
So therefore, do we need to remove this now, or just wait until?
So why don't we just give a clean copy to the board? So can you
Okay,
make that
so-
recommendation?
Yeah, okay.
Can I ask one final clarification, and this is just sort of to deal with the policy that you want? We've referred to it as registration, and I want to make it clear, I think the understanding is that this would simply be really a reporting. We're calling it registration, but we're not anticipating that the board staff is going to issue any kind of actual number or association. It's simply going to be data that you collect so that, you know where to go to look at the drugs that are within the pharmacy's control.
Correct. We don't even want to publicly post that at all.
Right.
That's not.
Right,
No
and we-
charge, we just want to know
No.
where they are.
Right, okay. So I just wanted to make it clear what we're talking about when we say registration, because I don't want to confuse terms, especially if you use that in other contexts as a registration.
Okay, so
And-
now do we have two things to do, or do we have one thing to do?
I think we want to fix C2.
I want to fix C2.
And
but-
then we also need to forward this whole revised reg
To the board.
to the board next week.
You haven't
Okay.
voted on the
Okay.
final
That's, that's my motion.
reg to board.
Okay, so your motion is
Is to
to,
remove the underscored portion of
C2.
C2
okay.
and to.
And C5.
That's already
No, we
been
already
done.
did C5.
Okay.
It's already been done. And then to send this to the board.
And if I can make that, leave that a little flexible so that I can verify with the Open Meeting Act that we can put this on the board agenda. Otherwise, I think what Ginny had recommended, that you have, the board has a policy about what to do on legislation in the interim.
Okay.
Okay.
So you can leave it open-ended to go to the board next week or to utilize the
The emergency response
emergency
to
response.
Right,
legislation.
which ultimately would end up before the board.
Right.
One way or the other, it's just.
Okay,
yeah.
that's it.
That's your motion?
That's my motion.
Second.
Second.
Any public comment? Okay, all in favor? All right, so are we done with this?
From now on, I'm going to call Alan
So we have a
second.
5-minute break,
Yes, could we
please?
get a 5-minute break? Definitely, and
Yes,
we'll go
that would
on
be a
to
good idea.
H. So we'll convene back, let's do 10 minutes, 11:40.